So I'd like to welcome Charlie Chung and our audience, which is from around the globe. We have a number of people from Australia, New Zealand, different parts of the United Kingdom, from Ireland, Singapore, and other countries across the globe. So welcome. We are recording the session, so it will be available within a few days on our website under the resources section of the StrokeAid website. Charlie is in Dunfermline in Scotland, and some of you may be in Scotland. It's always lovely to have somebody from my home country. I'm from Roslin in Midlothian in Scotland, and Charlie and I were just talking about the Ashley Ainsley Hospital and the college at the Ashley Ainsley Hospital where I trained back in the 70s, which is now part of the Queen Margaret University. Charlie's based in Dunfermline, but spends his time moving across different areas of Edinburgh and Midlothian in his role as the Allied Health Professions Stroke Strategic Lead for NHS Lothian in Scotland. And he's, as you can see, a consultant stroke occupational therapist. Before I hand over to Charlie, I'd like to make an acknowledgement of country. I'm here on the central coast of New South Wales in the eastern part of Australia, and I'll pay my respects to the original people, the First Nations people of this country where I'm based at the moment, and to their people in the future as well that are going to lead those groups. So Charlie, I'll hand over for you now.
Thank you very much, Annie. I'm very excited to be delivering this session today, and whether it's early morning, midday or evening to such an international audience. It's part of a workshop that I've been doing recently to the multidisciplinary team. So it's great to see so many people from different professions on this session. Now, we're just going to start off before I say really anything else is Annie has prepared a couple of polls just to get a feel of where people's knowledge of cognition is, and also just to rate your confidence in delivering cognitive rehabilitation too. If you wouldn't mind doing these, we'll put these up just now.
For anybody that's listening to the recording, you won't see the poll, but it's asking to people to rate their knowledge from no knowledge, some knowledge, or expert knowledge.
That's great. Thank you for completing that.
So we're up to about 85%. I'll just give people another few seconds.
Sure.
We've got 200 people online at the moment. Okay, I'll just end there in the interest of time and share the results on the screen. So we've got the majority of people have some knowledge, 86%.
Yeah, useful profile to have. And there's some information in this presentation, so I won't expect huge shifts from a 1-hour webinar, but hopefully it'll get people thinking.
Now, would you like me to put the next question up?
Yes, please, Annie, that'd be great.
Okay, please rate your confidence delivering cognitive rehabilitation.
And of course, it's appreciated that some of you may not deliver cognitive rehabilitation, in which case, there's no need to answer the question.
For anybody that's just joined, you may not see the poll on the screen if you've joined since the poll went up. So just be patient while we finish this. People are being asked, what's their confidence delivering cognitive rehabilitation? Okay, so I'll just end there. We've got 176 people, and 60% have some confidence, 30% are not confident, and 9% are fully confident.
That's great. So it lets me know that there's a kind of reasonable knowledge in this session, and and a bit of experience, some of it at the top end of experience. And for those of you that with lesser experience, hopefully this session will be useful in at least introducing you to the concepts, but also perhaps providing a bit of motivation to get engaged in some of the workshops that are delivered across the world, and so much easier now that many of these are online. So thank you for completing that, Paul. So here are the objectives of the session. And we really go into the theories of cognition in terms of the different cognitive domains. Attention, memory, and executive function will be the focus here, and be able to collaboratively identify goals from cognitive assessment findings and be familiar with how to creatively develop person-centered cognitive rehabilitation interventions. Okay, and again, the 1 hour session really touching upon these. The workshop actually goes into these in a more practical way. Yeah, I'm going to put that question up now, but just to let you know a little bit about my background and where some of this comes from. I delivered a post-stroke cognition clinic from 2016 onwards, but some of the scenarios, some of the work has come from both inpatient work and then inpatient rehabilitation work. So that's why I've been able to include parts from all parts of the stroke journey, and when people are working with our services. And the question there is, it doesn't really require you to answer anything here, just to requires you to reflect on that and the effect of cognitive changes affecting people that you've worked with in your services. And also, if you are a stroke survivor, what experiences of change cognition have you had? And as I move the slide on, this is not an exhaustive list, but you'll see things that you'll probably be able to relate to in your practice, or even in, how you've been feeling after a stroke. So difficulty following directions, frustration, anger, which can result from this, being overwhelmed with too much information, difficulty giving verbal responses, and in brackets I've put there, is that when somebody has that difficulty, is it an aphasia, is it cognition, is it a combination of both? It can be difficult to pick out. Variable for performance, performing well at one point of the day, and perhaps it changes in another part of the day. Refusals to participate, again, various reasons for that, of which cognition can be one of them. Variable engagement in therapy, the difficulty in setting goals, actually setting goals, agreeing plans, but for some reason not carrying them out, and failing to carry out self-exercise programs. It can sometimes be a topic of much discussion, and the variable communications with different individuals. I think we've all had the experience where somebody with a stroke in a working in rehabilitation will respond to somebody better than somebody else, or more effectively with the professional than their family members. So these are some of the things that we experience that can be related to changes in cognition. And so this is the workshop outline today, the session outline. I'm going to go into cognition first of all and look at attention, spatial neglect, because I always like to reinforce that spatial neglect is not a visual thing. It is actually an attentional concept. Memory, then working memory, looking at some assessment considerations before going into executive function. And there's another bit of background. Executive function was the topic of my PhD. I don't include any of that work in this session, but it's a separate workshop that I've delivered in various locations for the last few years as well. And then really just tying it together in a brief account of Tom's story at the end of the session. So here's the cognitive framework. And many of you I know will be familiar with this already. And I have a shortened version because some of you may recognize this pyramid and see things like, language has been sometimes put in here, visual perception has been put in here. But just to focus on cognition, I'm displaying this with the three main domains that we're going to cover today, and that is attention, memory, and executive function. Brief definition of each of these: attention, how we get information into our system; memory, how we hold that information and make use of it; And executive function, how we then make use of it for things like judgment and decision making and planning, problem solving. Often you'll see terminology such that attention and memory are cognition, or lower levels of cognition. Executive function can be termed as the higher level of cognition. And now let's go into this further and we'll take a closer look at attention. And here I've added 4 components of attention. You may spot that one may be missing, alternating attention, and actually deal with that later on in this session. But here we'll have the 4, and I'll give you a quick definition of each of these, because then what we're going to do is go into each one and look at the clinical implications of when these are changed and what the principles behind what we might do about it. So first of all, we'll have focused attention. And focused attention is we hear something, we see something, we turn our attention to it. That is focused attention, nothing more, quick, immediate. And you'll see for each of them, I've put in some of the neuroanatomy related to these. And I've done that not because, I do love neuroscience and neuroanatomy, but they can be useful clues later on during the assessment stage of trying to work out how somebody has been affected by the stroke, because often things aren't clear when people present to us. So you'll see that, and this is the start of the theme between things that are conscious, deliberate, and involuntary in terms of drawing on the executive system, or reflexive, automatic. Now, this isn't just focused attention. This thread runs all the way through cognition. So for instance, one of the areas which lights up when somebody focuses their attention can be the extrastriate cortex, which is the areas around the primary visual cortex and occipital lobe, because of that detection of from vision of motion and drawing our attention onto it. Then we'll have sustained attention, which we can think of as concentration, which is maintaining attention over time, and it's associated with an alerting network. Another term for sustained attention is vigilance, and being able to respond when something comes up, and related to the anterior thalamus. And selective attention, which is our ability to pick out a stimulus from competing stimuli. So open a drawer and you'll see lots of knives and forks, for instance, and if you've got a favorite fork or spoon, being able to pick out that particular fork or spoon. Or when you're in a party and you're listening out for your partner or your friend's voice amongst all the other voices, that is selective attention. And it's related to the orienting network, which is related to the right temporoparietal junction of the brain, a part of the brain which is to do with switching of attention as well. But the orienting network, a useful analogy of that is that it's like a torch beam where we shine our attention onto the point of interest, or we're able to shine the torch and highlight one thing amongst many other things, which is the mechanism behind selective attention. And finally, divided attention, which is attending to more than one stimulus at one time. And again, this is grounded in theories where our brains can be automatic, and our brains can also be purposeful at the same time. And often with divided attention, it can be challenging to divide attention onto 2 very purposeful type of tasks. But when we are doing it like walking and talking, one of these tasks will tend to be at a more automatic level. So these are the 4 main components of attention. And we'll take a look to see what impacts a stroke can have on these, and also looking at what can be done about them. But before we do that, just a special note on overt and covert attention, because I feel that this is often overlooked as an attention concept, but a very important one, particularly when we are working with people who have lost their movement and lost their ability possibly to move that torch beam, or do not have the postural control to be able to turn their attention onto something. So I'd like you to just think about something here when we think about overt attention. You'll be looking at your computer screen at the moment, and your attention is very much overt, it's deliberate. When we are involved in any kind of social conversation, when we're watching the TV, our preference will tend to be to use overt attention. And here's the thing, our heads are actually designed to be level and with our eyes level and our ears level for maximum processing of information. And an example of that is if you're just lounging on the couch, for instance, somebody comes in and tells you something which is really quite important, the tendency will be to actually sit up and get your head in a good position to take in that information, to be able to apply your overt attention, to take that torch beam of selective attention and to shift it onto the point of interest. But with people who have lost the ability to do that, they have greater reliance on covert attention. And what covert attention is to be able to attend to something without necessarily facing or looking at it. Now, whether you try something just now, you're looking at the computer screen, can you try to attend to something in the room without looking at it, maybe in the corner of your vision, it may be behind you, but just think about that thing or listen to any noises that are coming from out with while you have not turned towards it. And you can do that, it just takes a little bit more effort to do it, doesn't it? And it's always one of these things that a great ability to have if you like eavesdropping on people in restaurants and conversations, and or else like my wife Jacqueline, she's just wonderful at spotting animals and things while she's driving along a highway, and you know, for all intents and purposes, you're looking ahead at the road, but picking things out, you know, at the sides of her attentional fields, so much so that our children used to become quite distressed and used to say, where are you looking when you're driving, mum? And but in actual fact, she was making good use of her covert attention. So some of the implications from focused attention, as I've mentioned, is somebody who's lost head turning ability and may find it difficult to turn towards the stimulus of interest and rely on covert attention. So cognitive rehabilitation isn't necessarily only about cognitive interventions. Progress on postural stability, seating, and movement may improve the person's ability to focus on their attention. So do think about physical means in which to optimize somebody's ability to focus and sustain their attention. Implications from stroke-related sustained attention, reduced ability in holding attention on a stimulus. And one of the principles here is really that sometimes people have very little sustained attention, and grading the length of time can be useful, because sometimes the grading the length of time on a task can involve seconds. Somebody can carry on for between 5 and 10 seconds and then lose the thread of what's happening. They're not able to sustain their attention, and then other thoughts will take away their attention on what they're meant to do, or they would just simply fade away from the actual task that they're doing. So some of the rehabilitation activities can involve somebody with 5-10 second targets in the beginning in order to then increase that gradually. Selective attention issues can often result from right hemisphere damage, and even when we'll come on to talk about spatial inattention, spatial neglect, but even in people's intact hemispace, where they're able to apply their attention, they can have difficulty directing their attention onto the stimulus, just like the analogy of being unable to control the torch beam of attention that we all use. So adaptive means like eliminating or reducing other competing stimuli can be effective, and then gradually reintroducing as a person builds their ability to selectively attend on things. And then finally, divided attention. Attending to more than one thing at a time can be very challenging for the stroke survivor and often result in reduced attention on one or more stimuli. And I always think of an example within an inpatient setting. Perhaps, you as a physiotherapist have just moved somebody from walking with a walking frame to a stick for the first time, and somebody comes along while you're in the middle of a session and starts talking to your patient while you're working with them, and the patient begins to fall over because the person was able to maintain some divided attention while they were going a long time, but the person talking to them has just challenged that into a great way that the person's not able to carry on a voluntary conversation while still having their attention on the new walking method of using their stick. So reducing the need to divide attention can be a positive first step, but then gradually introducing aspects of something else that they need to attend on. And some of the activities that this might look like is somebody may be doing something, whether in the kitchen, whether they're dressing first of all, they have all their attention on it, but in order to challenge divided attention and to develop divided attention, something may be introduced into the background, for instance, the noise or a piece of music, or even in small amounts of conversation to start with as well, in order to provide that challenge. So this is just a little consolidation quiz which we'll work through together, and it is 10 statements, and for each statement I'd like to think of what type of attention that statement best represents. I have to say it is a bit artificial because when we're working with people, an experience of attention tends not to be just purely one thing or another. We have different combinations of these types of attention which are going all the time. But in the interest of just learning and consolidating this information, if you wouldn't mind going through with me these 10 questions. So following a recipe from an iPad while baking, just have a think about that, and then I'll put up the answer for each one. And it's intended to represent divided attention. Finding a specific serving spoon from a cutlery drawer. Yep, selective attention. Having a conversation while driving, hopefully not on a mobile phone. We're talking divided attention. Reading a book in a quiet room, no distractions, nothing else going on. An example of sustained attention. Turning your head in response to an object falling off a table, making a big clunk. Yeah, we're talking focused attention. Sitting up when someone suddenly speaks to you. Yep, example of focused attention. And picking out a conversation in a noisy room, very much an example of selective attention. And working through a series of simple calculations, that doesn't draw upon more complex cognitive processes will really load upon sustained attention. Counting the number of repetitions during an exercise can be an example of sustained attention, but also it can be considered divided attention as well when somebody's actually doing something while counting through. And stepping on the brake when a ball bounces in front of your car, an example of focused attention. So hopefully that little bit there over the few minutes gives you an idea or helps to refresh your knowledge of attentional processes. But do consider overt and covert attention too, if that's not a concept that's been familiar to you in the past. And as we move on to the next part of cognition, which is memory, please do post anything, question answers. If anybody's got any questions, I'm happy to respond to these as we go along.
And we do have one question, Charlie. I'd like to read it yourself about overt attention. If visually impaired or focusing on other attention, e.g. with eyes closed, would this still be overt attention in ways other than eye movements?
Oh, that's such a great question. And the answer is yes, because we just only have to close our eyes, and if we hear something, our spatial awareness is not necessarily just grounded in visual information. Our ears are designed to actually locate where sounds are coming from. So there can be a tendency to, if we, even with our eyes closed, I'm closing my eyes at the moment, can't help it. If we hear something from somewhere, we will be able to actually detect that, and the movement of our body arguably optimizes our ability to locate and attend to that noise. Having said that, we're able probably, now I just say this off the top, off the top of my head, that sometimes when it's auditory information, there is sometimes not the necessity as much to locate that sound. So an example of that is going into a restaurant, for instance, and there's music playing and your attention is on that music, but you probably don't put a huge importance on knowing where the speakers, that generate that music are coming from. So yes, overt attention without vision is still a thing, and hopefully that answers that question. A couple of other ones here which I'll address quickly. Relationship between language and cognition. Oh, that's a huge question, Norma, and that's a seminar, sort of within itself. Oh, I'm seeing, yeah. Annie would like to answer this question.
No, sorry. No.
Oh, all right. Oh, does that come up just because you've got your microphone on?
I think I just said that you were going to answer it live.
All right. So language and cognition have huge influences on each other, because if we're not able to, I'm not sure if I'm answering this question properly because it's such a huge question and great question as well, but some of the considerations around language are that if we don't have language, for instance, from an aphasia or for some other reason as well, and it's been a change from the stroke, arguably that is going to rely more on cognitive processes to come up with adaptations as means to communicate without language. But language is also heavily influenced by cognition, because as you will see from not just attention, but the other domains of cognition, when we talk, we form narratives, we form strategies in terms of how we talk. When we story tell, there is structure to that. And we have processes that are cognitive related in how well we actually deliver that narrative. We also make decisions on what we communicate, whether to communicate and whether not to communicate. And that is probably decisions that are based within executive function. So where you have language and cognition working together, that is probably the majority, if not everybody on this call. Where somebody has a stroke and they've lost their language, and perhaps the cognition is still a very good level, they're more dependent on their cognition. If somebody's cognition is impaired and they have intact word finding and ability to use language, select words in language, the communication may have been affected by not having the cognition to structure and make deliberate choices about the language used. I hope that is a taste of, a response to that question. Okay. The other couple of questions here. Do you use sensory processing and how the individual receives sensory input more of a visual learner than an auditory learner? Would you use this to increase attention to the task? That's a great question, and it probably highlights that we, and I include myself in this, probably don't pay enough attention to somebody's pre-morbid learning style. Like you say, people are, sometimes people are more visual, sometimes people are more language based in their learning. But what I will say in terms of and this up as anonymous attendee, to our anonymous attendee, is that sensory processing is key. And I worked with a gentleman just during the lockdown period who could not hear very well. And it was kind of put down to, he had cognitive impairment, his learning ability on certain aspects of his life was really quite challenged. He was a line dancer, having difficulty. His wife was actually an instructor, and he was having difficulty picking certain things up. And the interesting thing with him was he'd had problems with his ears for a lot of years and actually went in for regular de-waxing of his ears. But in regular conversation, you would never pick out that he actually had low hearing. But actually, during that period, he couldn't get regular National Health Service services in Scotland because so many services had shut down. He went to a commercial company that did earwax removal, and they did it so thoroughly that he was able to optimize his hearing, and most of his cognitive impairment suddenly disappeared, to let us know that a lot of it wasn't cognition related, but it was actually hearing related. So two aspects to that question is that yes, actually looking at people's preferred receipt of sensory input and also learning styles is key here, but also never underestimate the power of loss of senses in terms of making it appear as if somebody has greater cognitive impairment than what they may have. And hearing is probably one of these overlooked things as well, particularly with older people who, we tend to make incorrect assumptions that, oh yeah, they're going to be hard of hearing, when the hearing and the perception of auditory information may have actually changed from the stroke. So there has been some research about this, and Pauline Campbell in Scotland at Glasgow Caledonian University is one of the people that's done research and presented on this in recent years. Hope that's okay for that one. And from Michael, heard neuropsychologists refer to attentional control. What are your thoughts on this? I think an example would be serial sevens. I think this is going to be answered as we progress through this session, because one thing that I sometimes mention that I failed to mention this time was when you see the pyramid, the hierarchy of cognition, it's often useful not to think of it as a hierarchy. So we'll have executive function at the top, attention at the bottom, because it's the building block, memory processes in the middle. And I have an alternative visual representation that I tend to use, and that is having executive function central to the other cognitive processes. Because an example which relates to your question, Michael, is that when, say you're sitting listening to something, right, let's take the here and now. Somebody walks into the room behind you, yep, and you turn around, you focus your attention on them, you sustain your attention on what they're saying to you, then you have to make a decision. And you're thinking, well, this session's a bit boring. I think I'm just going to switch off and leave the session altogether, or else I'm going to turn my attention back to this session because I'm finding it interesting. That's my hope anyway. What you're using is higher level cognition to make that decision, and you're controlling your attention and bringing it back. And it also illustrates the theme that many, if not all, our cognitive processes can either be on a reflexive and automatic level, or they can be purposely controlled, and it will generally be our executive system that comes into this. And we'll actually talk about serial sevens in just a couple of minutes as well. But hopefully that's okay answers just now to these very great questions.
Thank you very much, Charlie. That was excellent.
Thank you. And picking out a conversation, noisy room, selective attention, series of simple calculations, not serial sevens. And for those of you that don't know what serial sevens is, it's the test which is 100. I'd like you to take away 7 and keep on taking away 7 until I ask you to stop, and the person's got to give the answer each time. But what they've really got to do is hold the calculation in their mind each time without being told what each subsequent answer is. But we'll come back to that. And working through a series of simple calculations, sustained attention, repetitions. In fact, we've done this just going back. I think I must have gone backwards during these questions. So spatial neglect. This is hugely interesting, and I love going into this area. And because also it has such huge impact on people who experience this. So here's one definition from Audrey Bowen, who has done the recent Cochrane reviews of interventions for spatial neglect or unilateral neglect. So a disorder which can reduce a person's ability to look, listen, or make movements towards half of their environment. two models that can be useful to be aware of. Representational model, left hemisphere attends to right hemispace, whereas the right hemisphere attends to both hemispace. Now, what that means is that when somebody has a left hemisphere stroke, they tend not to have a spatial neglect because the right hemisphere is still attending to both hemispaces. Whereas when the right hemisphere is damaged, then there is nothing attending to the left hemispace. That's fair enough. It's a theory, but to me, the attentional bias model probably speaks more with greater validity. And as you probably be aware, right through our neuronal system, we have a balance going on. So we have neurons which facilitate, we have neurons which inhibit, and we have regions of the brain which inhibit other areas of the brain and facilitate parts of function of the brain as well. And that's how everything is kept into balance. And what the attentional bias model does is it proposes that the bias towards the contralateral hemispace is stronger in the left hemisphere. So what that means is the left hemisphere has a greater draw on the right side of space, but the right hemisphere balances that out. Now, there's probably various reasons why the left hemisphere has a greater bias. It can be to do with handedness, for instance, and language, and most people being centered around the left hemisphere of space. Also, the left hemisphere is known to have a connection with forming relationships of positive emotions. People with left hemisphere stroke will tend to have greater levels of depression, for instance, than right hemisphere strokes. So it's a balance with the right hemisphere inhibiting the bias of the left hemisphere. But when the right hemisphere is damaged, that bias is left unchecked, so much so that the bias towards the right side of attention will be greater, so that the person is left with little or no attention towards the left side of space. And another reason why that model speaks to me quite loudly is I've worked with people whose spatial inattention and neglect isn't just 50-50. It's not just down the middle. Worked with people who have been left with a strip of attention, it's the best way I can describe it, down their right hand side. And that to me seems to support the attentional bias model. And then two main types of unilateral neglect, which can be useful to consider in practice. We have egocentric neglect, which is the one we probably most think about, is that somebody has a neglect, the left side of their world does not exist. Whereas allocentric neglect is more subtle, and it's the neglect of the left side, and I say left because it's mostly left side, the left side of each individual object or thing that the person is attending to. So with somebody with allocentric neglect, they may be able to direct their attention through both hemispaces and appear as if they don't have a neglect, but they're actually missing the left side of everything that they're attending to. So when they read something, a paragraph, it's not making sense to them, not because it's a language issue, but because they're missing everything on the left-hand side of each word that they attend to. And an example, the Oxford Cognitive Screen is a more recent screening tool for stroke that's come about in recent years. This is one part of it, the Broken Hearts test. You'll have seen tests like this. I think there's an apples test, which has shapes of apples which are complete, and apples which have a gap on the left side or the right side. And this is the same as that. You have hearts here, where there's full hearts, there's no gap. There's hearts with gap on the left side and gap on the right side. So somebody with an egocentric neglect, this is likely how they would complete it. And the instruction is, I want you to draw a line through, every full heart that you see. So this is the usual finding with somebody with an egocentric neglect, is they've been able to detect the full hearts, but the left side of space is not existing for them. Whereas somebody with allocentric neglect, and take a look at that, there are now hearts that have a line through them across the whole page, but have a look at how many of these hearts actually have a left gap. because somebody with allocentric neglect will perceive that particular heart as a full heart and won't appreciate that there is a gap there. Because there's a key difference between neglect and field loss in terms of hemianopia, and that somebody with hemianopia will generally be aware that they're missing something and will automatically turn their head to try and gain that information, whereas somebody with neglect will not appreciate that they're actually missing anything, which is why it creates such disability and makes it so challenging for rehabilitation and for recovery. Areas related to spatial neglect, and again I pull up the neuroanatomy because useful clues and when we're assessing, and very few people come along with just one of these effects in cognition, usually mixing cognition, language, physical effects, sometimes perceptual effects. And so how do we pin down what the effects are from the stroke? And having scan reports can be a useful way of giving us clues as to whether, so for an instance here is, whenever I might hear somebody saying, oh, they're neglecting the right side, okay, you might hear that. And in closer thinking, you think, well, the chances of that is possible, but the chances are probably less. So if the person has had a left hemisphere stroke and they appear not to be attending to the right side, is it a spatial neglect or is it not? And it's exploring the possibilities that they may have sensory loss on the right side of their body with a right hemianopia. So that could explain that presentation, which is maybe not a spatial neglect. And just knowing the locations in the brain which have been affected, can actually provide additional clues to what your conclusions are going to be. So common presentation of spatial neglect is people may ignore everything, usually to the left side. They may present, I'm not going to go through all these points in detail, I'll let you read these, but may present with anosognosia because very often spatial neglect is accompanied by people coming up with, strange conclusions, but also a denial that there's actually anything wrong at all. And so especially at the early stages, anosognosia can be present. And practically, you only eat food in the intact hemispace, miss the first few words of every line of text, which are covered. And implications, again, this unawareness. And one of the orthoptic recommended techniques is the head turning technique. And again, from the Cochrane reviews, there is nothing that's come out statistically or clinically significant in terms of what interventions should be given, but scanning training is one of the most promising types of interventions. But here's scanning training in a particular method, because again, when people scan, the experience that some may report is that things are just coming out of nowhere, and it's very disorienting, and probably because they're turning their damaged hemispace into what they're trying to look for. And instead, what one of our orthoptists recommended was actually get them into the behavior. If they feel as if they're missing anything or things are getting muddled, is to turn their head fully to the left as a starting point, always a starting point, and then to begin to look for things, scan while they're turning back round to the right, because in that way they are using their intact hemispace to find things, and which is less disorienting in the end. So useful tip, and I've certainly found that works well with many people. So here I'll have memory. And diagram of memory, where there's division into non-declarative memory or procedure implicit, and again, a memory that's more automatic, not as conscious and deliberate, whereas we'll have declarative memory that we declare, it's conscious, it's deliberate. And the things to point out here are that declarative memory particularly has two different types of memory. One is the episodic memory, which is the memory for things that have happened, but then there's the memory for facts, semantic memory, usually language-based memories of knowledge that we've gained. We might not remember how we gained it, but the memory for facts and meanings of words, for instance. And to point out here that useful to know the interplay between declarative and non-declarative, because many of the training that we do in rehabilitation may involve declarative memory at the outset, but the more something is learned, the more it then becomes a non-declarative memory. So for those of you that maybe use keypads to get into doors and there's a number there, you may have used your declarative memory to learn the number for that keypad. But after a while of using it, using it so often, it possibly then is now in your non-declarative memory. So much so, somebody asks you for the number, you might not be able to tell them, but instead you actually demonstrate the actions of the punching in with your hand to actually inform yourself of what the numbers are. And the short-term memory there, we'll come to that under working memory. And so non-declarative memory, the implications for these are them, sorry, this is just the definitions of what I've just spoken about. Conscious of time, so I'm just going to go through these. You'll see the neuroanatomy associated with these as well. And procedural memory, definition of that is you're riding the bike type of memory, things that have been learned and practiced. Okay. Episodic and semantic memory. And notable thing here is different types of memory, different areas of the brain. So which is why memory is not one thing. Somebody who has memory issues, it can be useful to define what type of memory that is particularly being affected by the stroke. Okay. And so I'll let you read some of these common challenges with memory after stroke. I'm sure you've had experiences of all of these. And one memory type that doesn't appear on that diagram is prospective memory, the memory for doing things in the future, related to that last one of failing to keep appointments or to remember to perform intended tasks in the future. And like the other Cochrane reviews, the Dasnair Cochrane review is not found, strong evidence, usually from the how robust the designs are in these studies. There's nothing conclusive in terms of memory rehabilitation. And that's why it's useful to think of memory as a process as well, and where attention is the taking in of information, because if we don't bring in information into our system through attentional systems, there's nothing to remember. Encoding is understanding that information, because if we don't understand it, it won't be stored. It's then stored, but it's stored in short-term store, and we need the consolidation stage in order for it to become a long-term memory. And these are some of the approaches along the processes of memory. So attention, basically ensure good practice with attention. Encoding, quantity, speed of information, complexity of information. Information should be understandable, should be meaningful. It should relate to, and this is Michael's question earlier on, it should be related to how best the person takes in information, and also building up the person's control strategies, not passively taking in information, but actually using, can you slow that down, or stop, I'm not getting that, or I lost that there. Storage, okay, again, the education that storage is a short-term process and probably needs consolidation for it to become a long-term memory. Certainly after a stroke, it probably needs a greater level of consolidation. And consolidation, repetition, association. Gentleman I worked with a temporal lobe stroke had no new learning, and we did a lot of consolidation work in terms of he thought that he was in another hospital altogether. So we would speak about the town that we were in each day. We would go to the window, talk about how he drove into the town in the past, skyline, what the different buildings were, in order to consolidate that information. And in the end, the information did begin to express the information, whether that was a result of the intervention, I like to think it was, or whether there was a recovery going on there anyways. These types of questions we can't really fully answer without the good research. And recall, and again, techniques of facilitating recall. And there is the Hebbian model, which is at play here, that it's all about strengthening connections between the neurons. If somebody can actually link up the bits of information to remember together, the neurons' patterns of firing is getting stronger. So by using methods of not just giving people information, but cueing them into information, theoretically, we're strengthening their neuronal connections. So rather than saying, oh, can you remember my name? My name's Charlie, and doing things like, oh, it begins with a C, I'm from Scotland, and using these types of techniques, we're giving the opportunity for somebody's neurons to fire in their brain and theoretically make these connections stronger. But one of the key things, and again, thinking about procedural memory, that non-declarative memory and declarative memories, many techniques, strategies that are used within memory are conscious, deliberate. So if somebody has a diary and they have a memory issue, they may not remember that they've actually got a diary. So practice is essential with that diary for that diary to become a non-declarative memory, a procedural memory. And the gentleman that I worked with on consolidation, he actually ended up with a piece of paper he would keep in his shirt pocket. And what happened procedurally was when anybody asked him the question about where he was and what happened, he had a couple of things written down on this piece of paper, and he would automatically, procedurally, just bring this piece of paper out and be informed by the information that was on this paper. And then just a little word about prospective memory, and really regarded as an executive function. And again, you can see from the neuroanatomy, prefrontal areas, and temporal lobe and hippocampus, areas which are related to both memory and executive function. And then working memory. And quick run through of working memory. I regard working memory as probably one of the most important concepts of cognition, and made up of these 4 components. And I'll take you through each one. So phonological loop, related to our left hemisphere, taking in language-based information. And working memory can be thought of like random access memory for computer. It's a temporary limited space store that we hold information active, that we can make use of it. Once we've made use of it, we can let that go. Somebody gives you a telephone number to punch in to order a pizza. Once we've used that number, we can probably let that go and not remember that number again. So it's like a piece of recording tape where information goes on. Once it's used, it can be wiped clean to make space for more information. Whereas in the right hemisphere of the visual spatial sketchpad, compared to a chalkboard, will hold visual information temporarily, and it can be discarded once that information is being used. But a more recent concept has been the episodic buffer, because when we have memories, we don't remember language-based information separate from visual information. We remember it as whole experiences, and episodic buffer is just the concept in which our brain pulls all that together. And again, related to the conversation earlier on, this isn't a passive thing. This is controlled by the central executive when it's deliberate. So the central executive will have a certain level of control over these systems on how that information is brought in and how it is used. And some of the challenges. Really, one statement about the challenges of working memory are people becoming overloaded. Also, what you might see are people who become muddled, or before they go and do a task, they are able to know what they're meant to do. They know all the stages, but somehow when they come to do it, they just can't execute what they said they were going to execute. And this can be an example of somebody's working memory being overloaded. They had enough working memory to think through what the task was going to be, but suddenly as they're doing the task, they're having to self-regulate, they're having to monitor what they're doing, they're having to make small adjustments, and the loading on their working memory has been greater than what they can actually handle at that time. And some of the implications for working with people is, again, providing instructions and information of speed and capacity that they can manage in a format that's most effective. Somebody with a left hemisphere stroke, they may respond better to things that are more visual and vice versa. So that talking to somebody an awful lot with instructions, etc., when they've had a left hemisphere stroke can actually be a disadvantage in terms of their work and memory processes. So this is just another quiz. I'm going to do this quite quickly here, and then that'll take us on to our last slides. And talking about your last holiday example of episodic memory, answering a history question and quiz, semantic memory, riding your bike on a familiar route, procedural memory, complex mental calculation like serial sevens, working memory, keeping a shopping list in your head before going to the shop, working memory, putting everyday clothes, yeah, there's a certain amount of semantic memory in terms of word meaning there as well, and putting everyday clothes on, procedural, remembering what you spoke to your friend about last week, episodic, keeping a procedure in mind while performing the actions, working memory, knowing that the capital of Italy is Rome, semantic memory, and remembering to keep your 3 p.m. GP appointments, prospective memory. Again, artificial in terms of separating the types of memory, but hopefully as a learning exercise and consolidation of memory, and that can be useful. Okay. So just a quick word about assessment. And this is the suggested assessment procedure. And really what underlies this is not just jumping into using tools and assessments, but gain that shared understanding. Take time to have the good conversation, because so much information can be gained in relation to somebody's cognition, communication ability, their preferences, who they are as a person in that initial conversation, because then you're using your screening and assessment tools to give you a more detailed definition of what's happening. But then that in itself can't stand alone. We need to feed back to the person to get their experience onto what your suggestions are going to be, on whether that is actually the case or not. And ongoing good conversation to identify areas, or goal areas, which are meaningful to them. And I've said this before, but use your knowledge of neuroanatomy, because the questions are, is this language? Is it an executive function thing? Is it an attention thing? It's only part of the picture in terms of using the assessments, but where has the brain been affected? And that can give some clues as well. So let me just run through quickly these slides here. Okay. And the idea is, most of you will be familiar with the Montreal Cognitive Assessment, and it gives a final score. Now that final score is useful in terms of knowing whether somebody has a suggestion of a cognitive impairment or not. But two people with the same score, for instance, can vary considerably depending on what parts of these tests they've been successful on or not been able to complete. So when you look at these, the labels on these don't always tie into the cognitive framework. And I have these listed here in terms of the trail making being a working memory task. Somebody has to hold the instruction in mind. I'll just run forward, naming these are pretty self-explanatory. The serial sevens have been mentioned, very much a working memory task. And the fluency is under language, but fluency, naming as many words as you can in 1 minute, that's actually an executive function task, because it's about strategy formation, understanding, concept formation, and flexibility. And then the delayed recall, but bearing in mind that that's just verbal memory and doesn't account for visual memory. So the limitations of things like the MOCA and many other tests that were designed for dementia are that they are very language dependent. And that's where the alternative of the Oxford Cognitive Screen has been a useful one to come along in recent years. And rather than an overall score, it provides a profile of somebody's cognition. Now, Annie, I'm aware I'm running out of time very quickly here. Are we good to go on, or?
Yeah, I know you've only got a few more slides, and you've got a case study of somebody that you want to apply that to. So yes, that's fine to take a little bit longer.
That's great. Thank you very much. And because this has been recorded, if people have to go, fully understand that. But hopefully you get the recording back, because we're coming into the area that I love, is executive functions, what I did my PhD on. But just to demonstrate the rest of the Oxford Cognitive Screen, these are the components of it. And take a note that the Broken Hearts test is there. So it does have some stroke-related tests, being a stroke tool. And then an apraxia screen as well, in terms of the gestures.
Is that a test that people have to buy or subscribe to?
They have to subscribe to yeah, this is actually for public organizations. This is free to use in terms of the license, and people can just go on the website and access it. For private companies, there is a payment involved, and there are videos on how to administer the test as well.
I know it's becoming more popular in Australia.
Yeah, I've certainly found it useful myself because of the profiling nature of it, being able to come to conclusion of what, rather than just a simple score, it is certainly more informative. But when people are using other tests like the MOCA or the Addenbrooke's assessment, these can be used to profile as well, using the cognitive information that we've gone through today. And so each subtest has a cutoff score, and it's used to generate the profile. So the shaded areas are the areas that demonstrate the areas where somebody has perhaps scored below cutoff point. And overall, it provides a profile of somebody's cognition. And it's a screen. So this is just a feel for how things are going. So it needs to be related to actual function, real life function, and perhaps other standardized tests, which will delve deeper into each cognitive domain. And it can also inform our assessment summaries as well. So these are some of the conclusions that can come from the application of the cognitive framework. Okay. So finally, we come to executive function. No agreed one definition, but all definitions tend to, list executive function as a series of different processes. The neuroanatomical picture you'll see there is that executive function used to be thought of as a kind of frontal lobe syndrome, probably because many people with traumatic brain injury ended up having the frontal lobes damaged. But you can see from here that the frontal lobe is connected to various input areas in the back of the brain. So the information from these areas need to come to the areas such as the prefrontal cortex and the anterior cingulate, for the processing, for executive function processing. And just a little word about terminology. Schemas, are action programs, can be very brief, such as head turning, or more complex. And contention scheduling is a term used for when we select schemas automatically. So again, this theme of automatic or deliberate. Something suddenly falls off your table, you just reach for it quickly, you're using contention scheduling, you've not needed to employ your executive function to do that, you've just done it as an automatic response. And to describe this model really describes the other influences of executive function and how executive function is organized. I do like this model, but I'll explain it. The lower part of the model is the automatic part of how we choose action schemas and carry them out. The middle level is executive function, deliberate use of schemas and selection of schemas. But the top level are the values, beliefs that influence our choice of executive function, selection of schema. So I'll put this into a kind of real life type of example. You're learning to drive. Everything is very deliberate when you start to learn to drive. So you're very much in the executive function level. After maybe a few months or so, things begin to get automatic. that you don't have to think about using the gears and fastening seatbelt, etc., so that you're in basic knowledge system. And then how you drive is dependent on your values and beliefs, whether you are a young roadster and you love Fast and Furious and you want to really take, or whether you're a very careful and deliberate driver because you have a great belief in safety. And another example of this is that we may be driving along, we're in basic knowledge system, we're on our way to work, familiar route, but we encounter roadworks, then our executive functions have to kick in that middle system. But then our top system comes in because you think, well, I'm desperate to get to work and work can't survive without me. So these values and beliefs may influence our executive function system to form a strategy that it may take us 3 hours longer, but we're going to get into work regardless. So you can see how these three operate together. And again, when you think about divided attention, arguably, if it's more than one thing, one of these things is perhaps in the executive function system, while another one of these things is in the basic knowledge system. And this is just routine executive, carrying on the theme, dress new jacket, tea. I'll just pull all these up. I think you'll get the idea. An interesting note, executive function required for tasks which are novel, complex, difficult, dangerous, or require error correction. And I put this in just because I've had more questions in recent times about where does emotion come in. And this is a different session altogether, but just to demonstrate the model of where we're having a look at the areas which are involved in processing of emotion. You have the cingulate gyrus, you have the hippocampus for memories, pardon me, and these result in two streams, the thinking stream and the stream of feelings, which are connected with each other. This is an old theory from the early 20th century, but relating it to current neuroanatomy. And again, you see that the same levels where the ventral part of the limbic system, which is the emotional system, is related to executive function, and the dorsal system is related to emotional processing. And this is in the brain is where the two come together. Okay. Sorry, I think I mentioned it the other way around there. So dorsal systems are cognitive functions, executive functions, ventral functions are emotional functions, olfactory functions as well, because that part of the brain was once known as the smell, the smell cortex. And 5 components of executive function. This was work that I did for the Cochrane Review in 2013, because each executive function definition was just a whole series of different types of components, and through a distillation process came down to these 5 concepts. Okay. Concept formation, understanding the situation. And again, just through want of time, I'm going to just quickly go through these, but you can review this back and have a look at what's on the slides. But in short, it's challenges with concept formation is somebody not understanding what's going on, which will then relate to goals and the execution of these goals. Planning, forming the concepts and the understanding, and then selecting the goals and pulling in the stages that are required to execute the plan, and some of the challenges there. Okay. And initiation. And this is an initiation not based on emotion as such, but just the imbalance between the cingulum and the supplementary motor area, where when going back to the theme of inhibition and facilitation, the cingulum is related to arousal, supplementary motor area is the inhibitor of that area. So if the cingulum is affected, then the supplementary motor area can create too much inhibition. So somebody may be interested, their mood may be okay, they can understand, they have concept formation, they just can't start the task without a cue. Okay. And again, just as I said there. And inhibition, the ability to stop prepotent behaviors. So things we do automatically. Somebody's always been used to stepping up with their right foot onto the first step, for instance, of a staircase, and suddenly that is their weak side, and they have difficulty inhibiting that behavior of always stepping up with that foot. And then finally, flexibility, which you'll recognize could probably be thought of as alternating attention, being able to shift sets and being able to shift from one task to another. And it can be done in a reflexive way, automatic way, or it can be deliberate using executive function. And just to say, people are particularly interested in the executive function part. I do a workshop on my concepts of executive function as well on this. And I'm just aware that we're just doing a whistle-stop tour with this. So I'm going to go through the next slides quickly because these I've just listed the published interventions related to the different aspects of executive function. Okay, I'll move on. And again, in Cochrane Review, like the other reviews, nothing statistically significant was found from meta-analysis. And I always appreciate the challenges of doing this type of research because many of these interventions were a kind of one size fits all. But the interventions in reality are so individualized that very challenging to perform trials of any great size and accounting for the individuality between the different types of intervention delivery. Okay, and these are the various practical tips in terms of delivering interventions for each part of the executive function, for each executive function component. And I'll move these slides forward. I'll just pick out one or two as we go through. Pause strategies are found useful because often people with a lack of inhibition, you almost feel as if they're impulsive and will just carry on regardless of safety or quality of what they're doing. And the pause strategies can be a useful way which they can adopt as a behavior to just stop before carrying on to the next stage or stop before carrying on. And flexibility, external strategies can be used, such as queuing sound. So much easier now with having phones and different electronic devices and setting up timings for cues to be made, and also smart speakers now as well that can be used as well. And then these were some of the published research that was about targeting multiple. It wasn't just looking at components, but looking at executive function as a whole. And just a slide on Levine's goal management training, internalized strategy, particularly when people are in the middle of a task and the first step is stop. What I'm doing if they're getting into a muddle, and then going through these steps in order to try and engage their executive function on the task again, planning and getting started, but then stopping if ever they get into a muddle again. And what this was a poll, but I think, actually, how many? We've still got 162 with us. We'll read through this. 72-year-old retired mechanic who was admitted to the acute stroke unit with a left arm and leg weakness. By day 5, his weakness has improved considerably, but appears to have difficulty finding his food and drink utensils, even when they're on his right side. And when working on his slurred speech and language therapy, he usually participates for around 10 seconds before commenting on something he sees in the room, or he tells a funny story. And when someone speaks to him from his left side, he turns his head to the right side. What cognitive domains appear to have been affected? So this is just a bit of a consolidation exercise here. We'll have a poll set up for this.
while we're waiting for that to come through, one of the questions is, are there any courses or workshops, particularly online, that you can recommend or that people have gone to for improving their knowledge in this area?
And now you may have come across the stroke awareness, training and awareness. It's Chest, Heart and Stroke Scotland, and we have just completed a competency module which is online now, and is by June we're hoping to finish the advancing module. These are short modules; they don't take long to do, and there's a little bit of a test just for your own certificate at the end of that. So that's an online thing. On the 3rd, we're aiming for the 3rd of July, but from the University of St Andrews in Scotland, the medical school, they are hosting another one of my multidisciplinary team cognitive workshops, and it's a whole day workshop of this, what we're covering very quickly here, but with a lot of practical exercises within that. And there is the online Braintree training as well, and I'm aware I'm just giving the UK ones here, but I think there are ones from the US. I'm not sure who in Australia, for instance, is delivering cognitive rehabilitation.
I don't know that there are many options within Australia that I can think of. If there are, people can put that in the Q&A. I know on Facebook, quite a few people have talked about the American College of Rehab Medicine have a work and an online training course that people can attend that's very highly recommended by some of the occupational therapists. But I can't give you a citation for that. I might
Sure.
open the poll now so you can see the results, because we've got about 80 people who've responded so far.
Okay. So the majority are on selective attention, sustained attention, spatial neglect. Great. So you picked out the 3 components of these. Thank you very much. I'll shift the slide on. Yeah, but please, anybody, get in touch with me if you need to know some of the UK type of courses that are available, and I'll do bespoke courses for various areas as well. I've had a request in from another region of Canada to deliver a bespoke course for them as well. So this is the answer. So that was the intention: selective attention, sustained attention, and spatial neglect. And then we'll move on to the next question here. So next, Paul, what would be an appropriate combination of intervention activities? And you can select more than one.
So for anybody who's listening to the recording and has stayed online for this long, we've got a choice of making a full meal in the therapy kitchen, or finding clothes using a head turning to the left strategy, or a third intervention might be reading practice of preferred books. Fourth intervention might be using Xbox platform games. And the fifth intervention is timed activity finding 2 objects using the right hand in the right hemispace. And people can select more than one of those 5 interventions. This is a nice way of applying that knowledge that you've just been covering. We're up to about 50% of the people online have completed this question.
Okay.
Just give it another 10, 15 seconds.
Sure.
Okay, we're up to 60%. So here are the results.
Good. Okay, so we've got responses for each of these things. And just before I move on to my slides, thank you very much for answering these. And one thing that my response is based on is the avoidance of overloading someone's cognition. So sometimes the bigger tasks, might be the things to go for, but actually in the early stages, they might be overloading overloading somebody's cognition. So this is where we have to proceed with care. And the ones that I certainly have are the clothes finding user head turning to the left strategy and the timed activity of finding two objects using right hand and right hemispace. Xbox platform games, they can be very useful, but in this type of situation, the speed at which they go to, unless we can find ones which are particularly, appropriate speed and complexity for Tom, might be difficult to engage with. Reading practice of preferred books, again, good, but I would have selected that one had it read graded reading practice of preferred books. It may have started off with a certain paragraph, it may start off with a section of the book, and again, that grading is essential here. And similarly, making a full meal in the therapy kitchen with so many effects on cognition, it may be wise to start off with a partial task in the therapy kitchen and to start with locating items, perhaps pouring water, perhaps filling a pot, as long as that subtask is meaningful in its own right and a complete task within its own right. Thank you very much for your engagement in that task, and hopefully the responses that I have make sense. And the key take-home messages, here are cognitive changes can impact on people's rehabilitation. I think goes without saying. And identifying which cognitive domains are affected and addressing these in sessions can improve the quality of participation in rehabilitation. Okay, so being more specific is the message. They're not just thinking about cognition as a whole, but what's actually happening within someone's cognition. Using screening assessments in combination with other screens and assessments can help build a profile. That profile can be very informative about what interventions to use and what goals to set. Have a good conversations to inform meaningful collaborative goal setting, and management strategies can include some restoration. In terms of working memory, there are promising interventions, particularly on people's working memory capacity. Also speed as well, although we can't change how quickly the neurons fire, in terms of how somebody can engage quicker in the tasks, can be influenced through this type of work. And many adaptive and environmental changes as well, in terms of simplifying the environment, but then grading the environment, again, to promote recovery and the right level of challenge. Okay. So just back to the last polls, just to finish off again, and thank you very much. And also thank you for those of you that have stuck around for this additional time as well. I'm aware that I've run over significantly in this session.
Here we go. And I might remind people who are still online that we do have another recorded lecture from more than a year ago by Emma Schneider, which is in our library of recordings on the StrokeEd website under resources. So that's got a slightly different focus to Charlie's content today. And it was, like Charlie's session, very, very popular. Here we are. So we've got 75% of people reporting they've got some knowledge and 25% saying they've got expert knowledge at this level. And confidence, we'll have a look at the confidence one.
I love that. The best part of that is that we shifted from people with no knowledge into, so there's now nobody with no knowledge.
Yeah, that's right. And I'm just going to end it quickly before people leave. So we've got 76% with some confidence, 21% fully confident, and a couple of people are still not very confident.
Sure, that's fair enough. Thank you very much, everybody, for completing that. And again, it's always great to know. Okay, so thank you very much, everybody. It's been a pleasure delivering this session, but as you can probably see, it is a huge area. And there's a lot of this, which is just wonderful when delivered in the workshops, and also going into, in my case, particularly executive function. And I've always loved delivering the executive function workshops in addition to the multidisciplinary team workshops too. But for any questions about training or anything else, please don't hesitate to get in touch. And I'm happy to take any questions here if people have the time.
We've just had somebody asking whether you get any certificates of attendance. No, I'm afraid we don't have the administrative capacity for that with a free event like this, but you do have the email that you received as evidence of your registration. And I can see Colette from Australia has mentioned that there is an Australian version of the Oxford Cognitive Screen and online modules of how to administer it on the ACI Stroke website or the Informe website of the Stroke Foundation. So
that's great. Thank you, Colette.
Australians to know that. And we've got 2 or 3 people saying it's been very helpful, Charlie.
Oh, that's lovely. That's always so encouraging. Thank you. Thank you very much.
Katie, I've done, and she's mentioned, Bianca's mentioned that the ACRM Cognitive Rehab course is one of the best courses she's done.
Brilliant. That's great.
Okay, I'm going to finish there, and thanks everybody for joining. We have another webinar on Wednesday that Simone Dorsch is coordinating on neuroplasticity, and then our final one for this month next week, which is on balance training on Wednesday next week.